are not able to be here tonight. And you can also share this recording with your colleagues, your faculty, other faculty, other residents, if you think they might be interested. Use the chat to ask questions, make comments. If the speaker says something, ask a question, you can respond in the chat. And we will have time at the end for some discussion. So feel free to unmute yourself and raise your hand. Use the little icon to raise your hand if you want to share something. Just a quick overview of the agenda. I'm doing the welcome. We'll have Philip Day, who's going to talk about narrative medicine, Susanna Evans, who's going to talk about hereditary cancers, and then Anya Karavanov, who is going to talk about the Bring Your Brave campaign specifically. We do have a lot to get through, but I think we should be okay and end on time. I want to especially thank the National Association of Chronic Disease Directors, which Anya is a representative of, for their support of this. They, with their CDC funding, are helping us run this collaborative. I think it's a kind of a win-win. We wanted to do more at FMEC to engage across residency programs in learning collaboratives. They have a campaign that we think is of great and of interest, and we wanted to talk more about how it could be used in both training and clinical care. Just quickly, and we will share all these slides so you can have this to read at your leisure, but the collaborative is really trying to educate the family medicine residency training programs on the campaign and the available resources, and then talk about and figure out how those can be used in both training and in clinical care. And we're hoping that your programs, through participation in this, will come up with strategies and ways to use the materials, and maybe additional projects and additional things you want to research or learn about that we can then use to go forward in the future and help other residency programs learn about the materials and use them. We are going to have 5 learning sessions. This is the first, so welcome. The next, each month will be about a different topic. Next month, really, we're going to ask you to kind of just share your reflections on the materials we've shared and how you think you might use them. It's going to be a lot of reactions and sharing. So please make sure to join for that one. Then we're going to talk about integrating those strategies into patient care, into residency training, and lastly, how you might make referrals for patients in your community, and some discussion of that. Thank you all for joining. We have 10 residency programs participating. We'd love to have you all introduce yourselves, but we didn't have time tonight, so we'll be setting up some ways to do that via email and other strategies. Nice representation throughout the FMEC region too. We have 14 states in our region, and I think we have 6 or 7 represented. So we're happy to help make this work across state lines and across residency programs. I also want to make sure to acknowledge our advisory committee. We have many of them on the call tonight. Tracy Conti, Philip Day, Susanna Evans, Adam Perrin, and Sarah Inés Ramirez, who are all helping to shape this and will be your kind of faculty experts, and also kind of a sounding board for you if your residency program wants to talk about what you're doing. They'll be happy to help. So thank you so much for the time they're putting into this. And with that, I am going to turn it over to Philip Day, who is going to be our first presenter and help moderate through the rest of the session. But we're looking forward to a really exciting session tonight.
All right, thanks Scott. And thank you everyone for coming tonight. I've got a few slides I'm going to share with you. Here we go. Can you all see that? Rebecca, Scott, everybody see my slides okay? All right, full screen. There we go. All right. So welcome everybody. I'm Philip Day. I'm going to speak very briefly about 10, 12 minutes on narrative medicine. Very general background introduction to some of the basics, some of the benefits, and we're going to conclude with a little bit of look at some of the research and literature for use in clinical patient care and in education. So here's our contents. Like I said, a little bit of background, foundational stuff, and then we're going to look at how as it's been applied and what sort of evidence can be found in the literature for its application in these two regions. So narrative medicine really falls under or within this broader category of the medical or health humanities, which I'm sure y'all have all heard of, if not participated in, which really is this notion that that there is knowledge, facts, and information that can be gleaned outside of the biomedical and biological and basic sciences. And we find this as early as the Flexner Report. I mean, we can talk about narrative in medicine probably going all the way back to Hippocrates, but specifically within the US and in the system that we work in, at least back to the Flexner Report, right, over 100 years ago. And in this report, I sort of pulled out this quote. The report mentions, that chemistry, physics, biology give us one set of facts, But there's a whole other region, a whole other set of facts that requires, and I quote, an apperceptive and appreciative apparatus to deal with other more subtle elements. And so the idea is that the medical health humanities narrative medicine really allows us this portal, another way into these more subtle elements. And we're going to be talking about those, or I'm going to be speaking about those for the next few minutes. But before we get to narrative medicine specifically, I think it's important to at least speak a little bit about the importance of narrative in experience, because that's really what we're looking for here, right? The stories of our lives, the stories that tell who we are outside of just the facts of who we are. And this has been a part of, I happen to have a PhD in philosophy, and so I know something a little bit about this in the sort of philosophical and theoretical literature within these two sort of sub-disciplines, hermeneutics and phenomenology. And again, we're not going to go into that too much tonight, but essentially what they say is that when we think about our experience, one way that we intuitively and naturally understand it is through narrative, is as a story. The idea is, just as we read a text and we translate and interpret what that meaning is, and we gain more knowledge as we read more of a novel and we roll it all together, that our experience is a lot like that too. And often whenever we tell our story, whether it's a cover letter, a resume, or just to someone new that we've met, it's in this sort of way, right? It's in this narrative fashion. And so the idea is really that by reflecting on our own story, we learn more about ourselves, others, and our interpersonal and intersubjective relationships and meanings that we create through those relationships and through those stories. Now, in narrative medicine, I mean, it's existed, like I said, longer than just Rita Sharon here, but she introduced the concept with a very famous, I think, famous essay in JAMA over 20 years ago, as you can see, called Narrative Medicine. Rita Sharon is a general internist who still practices at Columbia University and runs their program in narrative medicine. And she's written, as you can see, a book and has edited another book on narrative medicine. And she really is the sort of beginning of this of the sort of expansion of narrative medicine within medical training and in the literature itself. And in that essay, she tells us that what we're really looking for in physicians and what we're looking to cultivate is the skill that she calls narrative competence, or, and I quote, the ability to acknowledge, absorb, interpret, and act on the stories and plights of others. And this is a long quote here. I'm going to read it all, but only for a very specific reason. And so she expands on this idea of narrative competence and what it can do. And what it really does is gives us insight into what she says are the four main narratives that are at play within medicine. That is, the first one is the practitioner, the physician, or the provider, whatever your P word of choice is, with the patient. The personal journey through medicine, so practitioners in themselves, right, reflecting on our own stories. Acknowledge kinship with and duties towards other healthcare professionals, right? So the narratives we have with our colleagues. And finally, the larger discourse that medicine, healthcare has with the public. So those are the sort of the four, and we're going to come back to those in a second, the four main narratives within medicine that she thinks are important and that narrative competence can allow us to navigate. So how do we build this narrative competence? Well, not unsurprisingly, by reading, right? So she says we can cultivate it through reading literature, right? Reading stories, exploring the health humanities to appreciate other forms of knowledge, right? That are, again, outside of the sort of biomedical perspective on patient care. And I know this is family medicine, and so we work within the biopsychosocial model. And so this is something that really, I think, adheres and aligns a lot with the way that family medicine is practiced. And then practicing reflective writing. She says those are three ways that this narrative competence can be cultivated. And so if we think about it in practice, you know, as I said, well, what does it look like, right? Or how would we sort of mobilize this narrative competence? Well, as I just said, it's informed by the biopsychosocial model, right? You're really looking for the whole story of the patient in this patient-centered medicine sort of perspective. And it highlights the intersubjective and interpersonal domains of medical practice. And, you know, one example, I'm not going to belabor it too much, but I'm going to talk about chronic pain, is how they can complement, right? How the narrative approach can complement the more traditional clinical diagnostic approach in medicine. And so you can see this example of chronic pain on your left side of the chart here, you can see through the, sort of the diagnosis and treatment. You do your visual analog scale, then the patient then quantifies their pain intensity, right? So we have a number that gives us some sort of quantity or intensity that can be tracked over time. But on the other side, you also get this narrative evaluation, right? Asking the patient about their suffering. What is the impact of the pain on their life? And so what we get with this complemented or complementary perspective is the story of an individual and not just a patient with a number. As someone who had chronic pain for years, I can tell you about the importance of his shoulder pain, the importance of a physician really listening to my story of suffering and how it could and was eventually relieved. And so here are those four central narratives in medicine that I highlighted and that Sharon highlighted in her essay. So it's between the practitioner and patient, and self, colleagues, and society. And so when we look at these four, there's a sort of way that they expand, right? So if we can expand or focus on, rather than expanding, focus on the first narrative, right? That is between the physician, the practitioner, and their patient. He says, we can really cultivate through narrative competence this idea of diagnostic listening through empathetic engagement with patients, right? Which is a way to establish this therapeutic alliance and effectively engage with patients in their healthcare. The next is the practitioner in themselves through this form of reflective practice. So rather than, and again, I'm not accusing anyone on the call of this, but rather than practicing from a place of attachment, narrative competence allows practitioners to engage with patients and recognize the commonalities in our human stories, right? Where they dovetail between patients and physicians, patients, or physicians and their colleagues, right? And so I'm an ethicist by training, and so I do a lot of work and think a lot about professionalism. And narrative medicine, I really like this idea, really talks about professionalism as a conversation, as a discourse, as a category, or as more than just a category of action. It's an agreed narrative, right? This is what a good physician does. This is who a good physician is. And so when we think about someone who's acting unprofessional, or we think about the bounds and the boundaries of professionalism, it really is a narrative that's ongoing, that changes, and that adapts over time and with individuals. And then finally, with society, right? There's a lot of authority that's invested within medical practitioners and imbued within the field. And so that also leaves a lot of room for mistrust of that authority. And so narrative medicine, by cultivating this sense of an ethical narrative of what it is to practice, physicians can shape the narrative of US healthcare. Another long quote, not going to read all of it, just the highlighted part. But what she says is that physicians have to find ways, and she thinks it can be found through narrative medicine, to talk simply, honestly, and deeply with patients, families, other healthcare professionals, and citizens. And this is not in the form of scientific or rational debates, right? This complements those, but these are grave and daring conversations about meaning, values, and courage, right? And we get to those through listening to people's stories and then telling the story of medicine to society, to policymakers, to our elected officials. So again, I'm an ethicist. I get this question sometimes about ethical trading. Does it work? I think again that might be the wrong question to ask, but yes, there is some evidence that narrative medicine does work. It does have an impact on patient care. And so here's a citation. I'm not gonna click on this and look at a boring journal article, but I did want you to see sort of what these studies are before I just show you the results, right? So this was a study that essentially asked patients to write about their cancer pain, right, and how they were managing that pain, their suffering, their stories. And so what the researchers found is that patients who showed more emotional disclosure in their narratives experienced significantly less pain and reported higher well-being scores than patients who reported lower emotional, or who wrote lower emotional disclosure in their narrative. Causal? Not sure. Probably association, but there's something therapeutic about talking about our stories of suffering. This is another a little more recent study that has to do with doctors and patients as they're collaborating and conflicting over opioid prescriptions in primary care. And what they found and asking and interviewing the patients and the physicians, that these collected narratives revealed that patients focus their stories on suffering for chronic pain and on the role of opioid therapies to provide relief. And the use of narrative to explore chronic pain had a significant implications for improving the doctor-physician, doctor-patient relationship. What about education? I'm a medical educator, we all are. That's a big part of the Bring Your Brave campaign. So these are two more recent studies. So narrative medicine is a means of training medical students for residency competencies. So students perceive that through a narrative medicine training or perspective, they developed and improved their communication skills, enhance their ability to collaborate and empathize and be patient-centered, develop professionally and personally through reflection, right? Has benefits for medical students, equipping them with what they need in order to go on to residency and their own practice. And then finally, this is a study from last year looking at how residents talk about patients and whether or not that can be changed, improved through narrative medicine workshops. And of course, you wouldn't see it here if it didn't. And they found that having these sessions regarding language use and patient care shaped how interns thought about and used language during their clinical work, right? So by introducing this idea, this perspective of narrative medicine, it shaped the way that they talked about and to patients, and that this arose spontaneously during the interview. And so I just want to conclude with this, a few quotes here at the end, but this idea that narrative medicine provides insights into patients' values and experiences. It foregrounds the importance of stories in healthcare as patients, ourselves, our colleagues, and society. And research into the impact is still in code. It's still basic and new, but it does show some promising results. And so there's plenty of literature. I would encourage you to go look at it. There's some systematic reviews at this point where you can really look at this and sort of marinate on the findings yourself. So I want to close with just a few very brief quotes from practitioners and students who have been through or like I said, practice narrative medicine. This is a physician from Brown. So students and physicians need to know the anatomy of a patient's story just as much as the anatomy of the human body. This is a lecturer from Temple who says, I believe that stories have an incredible power. Understanding what a good story is and learning how to interview and ask questions will help you connect with your patients, understand them, and build relationships with them. This is a medical student from the University of Nevada, Reno. It not only makes me a better physician in the sense of being able to listen better and be more compassionate, it also helps you gain a better understanding of who you are as a person. And finally, from Rita Sharon herself in that article, narrative medicine is a commitment to understanding patients' lives, caring for the caregivers, and giving voice to the suffering. And with that, I am done. Thank you very much for your time. Stop sharing right now. And I'm going to hand it over to my colleague, Dr. Susanna Evans. Susanna, if you're ready, she's going to talk a little bit about hereditary cancers in women.
All right. Can you see my slides?
Yep, sure can.
So I'm just talking briefly about genetic risk assessment, particularly for early onset breast cancer, and why we as family physicians need to be doing it. Sorry, I'm not moving. There we go. So 9% of breast cancers occur in women 45 and younger. Women in this age group are more likely to have a hereditary breast cancer. Breast cancer in this age group is found at a later stage when it is often more aggressive and difficult to treat. And many young women do not know what their risk is for breast cancer, and they don't know the ways to manage the risk. As family physicians, we need to identify women at high risk for breast cancer and refer them for appropriate testing and screening. When we talk about early onset breast cancer, we're really looking at women between the ages of 18 and 45. Many of them are only getting their care from you. Quite possibly they are maybe an OBGYN in their life, but if you're not having this conversation with them, probably nobody is. According to the Bring Your Brave campaign, only about 45% of primary care physicians refer a woman with high risk for breast cancer for genetic counseling or testing. And I found in my research preparing the results of this one study that would just floored me, that fewer than 1 in 5 individuals with a history of breast cancer or ovarian cancer meeting select National Cancer Comprehensive Network criteria have undergone genetic testing. Most have never discussed testing with a healthcare provider. So that's really surprising to me because these are people who have cancer. I'm not only a presenter tonight, but one of my reasons for really wanting to get involved in this is that I am myself a breast cancer survivor. And in the spirit of narrative medicine, I wanted to briefly tell you my story. In my 30s, I had my first suspicious lump and a breast biopsy, and then my second, and my second landed me in the office with a breast surgeon. And at that time, I had the family history of a grandmother who had breast cancer, I think probably in her 70s, and my mother who had her first breast cancer. And what the breast surgeon said to me at the time was, you're high risk. Both my mom and my grandmother were older, and I wasn't really sure I bought into what he was telling me. And my mom had the BRCA testing and she was negative. So I thought, maybe not, I don't know. And then again, later in my 40s, I had an abnormal mammogram, which led to an ultrasound and a biopsy. And at that point, I saw a different breast surgeon. And also at that point, my family history had changed. So my mom at that point had her second breast cancer, and my sister had been diagnosed with breast cancer. Again, my mom and my sister were both BRCA negative, but they both had a variant that was classified as unknown significance. And so at that point, the surgeon said to me, like, you have to take this seriously. And even though the BRCA is negative, you're high risk, and we might not know why you're high risk, but we need to treat you as such. And started having me do yearly mammos, yearly MRIs. And I can tell you the MRIs were horrible because I'm claustrophobic, and I had to be medicated just to get into the MRI. And I wasn't always good, it would come up and it would be a year and I was supposed to do it. And then I would stretch it and it would be like, 13 months, 14 months, 15 months kind of thing. And then yet another biopsy. And that last biopsy, my surgeon's like, you can't keep doing this. Like you need to follow the guidelines. You need to get tested. And really sort of held my feet to the fire. Well, ironically, everything was fine with that biopsy. And when exactly a year later, I followed up for my mammogram the way she wanted me to, that mammogram was abnormal. That biopsy was not normal. And I ended up having an invasive ductal carcinoma. But the gist of the story is it worked exactly the way it was supposed to. So I was diagnosed early. My treatment was relatively easy. And I now am considered a survivor. So what are the risk factors for early onset breast cancer? According to the American Cancer Society, they've defined women who are at high risk. So if a woman has a known BRCA mutation, but also what I didn't know until I dove into this campaign was if there's a first-degree relative, a second-degree relative, or a third-degree relative with a BRCA mutation, that woman is at high risk. A woman who has a lifetime risk of breast cancer of about 20 to 25% or greater, according to risk assessment tools that are based mainly on family history. I'll get to those in the next slide. But these are women who are not necessarily BRCA positive, but like me, you're taking a lot of different things into consideration to determine the risk. anyone who's had radiation to the chest between the ages of 10 and 30 years. And then there's multiple syndromes, I think, just to sort of have in the back of your mind that if your patient has one of these, they are considered higher risk. So there's multiple tools. There's a link, which is the one that's highlighted in the middle in that teal color, which is on the Bring Your Brave campaign. And you can link in there as you start to go through the materials. The model that I was most familiar with is the Gale model, and that was the model that my surgeon used and that I have access to in my office. And then there's a summary of sort of the different models. The Cusick tire model, which I was not familiar with until I started to do this research, is supposedly the best, and the other ones may underestimate the risk. But the bottom line is that these are all tools that you can use to help your patient determine what their risk is. And then based on risk, who should be referred? So per the American Cancer Society, genetic testing is recommended for women at high risk to look at mutations in the BRCA1 and BRCA2 genes. While testing can be helpful in some situations, the American Cancer Society stresses that providers need to weigh the pros and cons with the patient. So I think it's really important for us as the providers to be able to have these conversations with our patients and to know what the pros and the cons are. ACS strongly recommends that women first talk to a genetic counselor, nurse, or doctor who is qualified to explain and interpret the results of these tests. So, you will see that, you can actually refer people for testing without going through genetic counseling, but it's not recommended unless you yourself become really comfortable with the genetic counseling. The USPSTF, I think that's, the society we all kind of fall back on for the best use of really good evidence-based medicine. They recommend that women who have one or more family members with a known potential harmful mutation in BRCA1 or BRCA2 gene should be offered genetic counseling and testing. And women with an identified increased risk should be referred to a genetic counselor who can further evaluate the risk based on family history, discuss the pros and cons of testing, and arrange for the BRCA testing if the patient is ready to proceed. And then finally, what does this mean, right? So if we determine our patient is high risk, how does that change what we're doing? And so the guidelines actually at this point are really very clear. And I can tell you that even 5-6 years ago, they weren't so clear. But once a woman is determined to, and even actually, I keep saying women, but men too. Once a person is determined to have a BRCA1, BRCA2 mutation, or with a first degree relative with these mutations, then they should be getting a mammogram and a breast MRI yearly, starting at age 25 to 40. And the age at which you start depends upon the type of gene mutation and also the youngest age of breast cancer in their family. The other recommendation, as I'm sure you're all aware, is that we're not recommended to routinely teach or do breast exams with patients anymore. But in patients who are high risk, clinical breast exams are recommended every 6 to 12 months, beginning at age 25, in the hands of an experienced provider. And then the American Cancer Society has very similar recommendations for a yearly mammogram and a breast MRI. They differ just in that they recommend to begin screening at age 30 or at age recommended by the healthcare provider and to continue for as long as the patient is in good health. And that's all I have.
All right, thanks, Susanna. And now we're going to turn to our next speaker, Anya, who's going to tell us a little bit about the Bring Your Brave campaign through the CDC. Anya, it's all yours.
All right, are my slides okay? Can you see everything?
Sure can.
All right, thank you so much. Thank you. Well, thank you, Susanna, for that introduction. So with that, the mission of the Bring Your Brave campaign is to inspire young women to learn about their risk for breast cancer, have meaningful conversations with their healthcare providers and families about hereditary cancer, and live a breast healthy lifestyle. We're also target healthcare providers to help them understand barriers patients face in dealing with hereditary cancer. And this is critical because identification of BRCA mutation has potential to empower patients with options to detect cancers early or prevent them altogether. Conversation with healthcare providers about family cancer risks are critical. But as you have heard Susanna say, only few patients have, and women of color are a lot less likely to have these conversations than non-Hispanic white women. So recently, CDC conducted a 22 focus group study with Hispanic, Black, and Native American women ages 18 to 44. And among other things, the study addressed motivations and barriers to accessing genetic counseling and cancer screening. And according to the results of the study, Blacks and Hispanics most often reported factors like perceived costs, lack of health insurance, lack of access, fear, lack of information, lack of trust, as well as being written off by providers as being too young to be concerned about breast cancer, as barriers to talking to healthcare providers and pursuing genetic testing, genetic counseling and testing for hereditary cancer. So on the other hand, women are more likely to have family conversations when they have knowledge of how to discuss family history, what to ask, have supportive family members, and feel comfortable discussing the topic, and be prompted by their healthcare provider. So, this also aligns with other research indicating some disparities in genetic testing, cancer risk management among certain populations, including Black and Hispanic women. So one of the campaign's main strategies is to feature real women and men, as you will see, as well as healthcare providers to tell their real stories to bring this issue to life. So patients that we featured dealt with prevention, risk, family history, and survivorship. So, and as you know, and as Philip has pointed out, stories can make issues feel a lot more real and more identifiable. So plus stories are more engaging than traditional educational communication materials because they really tap into your emotions. So our stories actually happen to work for both patients and healthcare providers. From a patient point of view, stories can help drive home the reality that young women can be personally affected by breast and ovarian cancer. They also help them feel less alone in their struggle, worry, or fear. And when you see someone who looks like you, or looks like someone you know who could be your peer or your family member, you may be much more likely to make a connection between what this person is sharing and what you should know. And women in our stories also help model the desired behavior. So they seek genetic counseling, they talk to providers, they talk to their family members, they seek treatment. So we're also increasing their self-efficacy. So from the healthcare provider perspective, patients talking about their personal experiences with illness, treatment, or any aspect of healthcare can help providers improve care by understanding the issues that patients faced, right? So, and this goes back to what Philip was talking about, right? Stories encourage doctors and other healthcare providers to listen to patient stories as a way to more fully understand their experience and their needs. And learning about how patients deal with certain diagnoses or about the many non-clinical factors that impact the way they may cope with treatment or recovery can improve the way providers approach patient care. So in holding the patient story as central. Narrative medicine essentially shifts the doctor's focus from the need to problem solve to the need to understand. And then as a result, the patient-doctor relationship is strengthened and the patient needs and concerns are addressed more effectively. So we have produced a whole suite of storytelling activities. We have a conversation simulation that teaches people how to have these difficult conversations within the families, because half of the time, before they even come to you, they need to know their family history. And those conversations can be very, very difficult. And we produced a series of stories professionally, as well as through Story Center and storytelling workshops, and you will get to see and get familiar with all of these materials throughout this experience. So I wanted to, do I have time, Rebecca? Okay.
Yes.
I wanted to share a few stories, one story from the patient and one provider experience. So I'm going to end this and go here. All right, let me make sure you can.
When I was 5 years old, my mom was diagnosed with advanced breast cancer. She was misdiagnosed, I think, 3 or 4 times. So by the time she was diagnosed, it was too advanced. And, she passed away when I was 5. So when I turned 17, my OBGYN recommended that I start regular ultrasounds due to my family history of breast cancer. And they found a suspicious mass in my left breast. Thankfully, it was benign, but eventually, after a few years, they found another suspicious mass. And I remember just being terrified.
So when I first met her, breast cancer, her mom, it's not something like she spoke about a lot. She just kept it private. So it wasn't like she told me too much, but yeah, I just remember her being concerned, for sure.
Thankfully, the mass was benign. But after that, for us, it was kind of a sore topic in the beginning of our relationship. And I remember you telling me once, like whenever the topic of your health comes up, you get like very standoffish and you shut down. And I remember hearing that and thinking, oh my gosh, you're right.
But just over time, she started talking about it more, started sharing more about it.
Telling Larry like how I really had to start navigating what all of this meant to be high risk for breast cancer. So after seeing all of the research, I decided to have the preventative surgery. And I remember before flying out for my preventative mastectomy, telling Larry, like, we don't have to do this. You don't have to come with me. We don't have to like be on this path together. And I remember him being like, of course I'm coming with you. I had my preventative mastectomy at the height of COVID. Definitely the most difficult thing that I've experienced physically. And then also, I couldn't have my family or friends there except Larry. And he was incredible. And, he was just always there and was always just like a calming energy while I was like, not.
I think I just always kept up pretty upbeat, pretty much just played nurse to her and did whatever bidding she wants.
I had heard that you won't be able to shower for a while. You'll want your hair braided. I remember thinking like, oh my God, like, who's going to do that? I can't do it. And that's when I learned that Larry knows how to braid hair.
You're good. Well, I just happened to know how to braid hair, and she never really got that experience because obviously her mom passed, and so
he became a pro hair braider, I would say.
Thanks.
I didn't know that was a type of support I needed. And I'm so grateful. I think I realized inside for me, like support is so important. For me, it was what got me through processing the grief of my mom. It got me to be able to have this preventative surgery, to now be able to share with others my experience. And that means more to me than I could ever express.
Do we have one more? Okay, all right, one more coming up. And this one is from the provider perspective.
It was a Tuesday in early fall, about 2 months after you finished your chemotherapy, when you came to see me in clinic for a follow-up appointment. You came to clinic with your mom. She came to every single appointment with you and sat beside your bed on alert when I met you in the hospital for the first time several months earlier. Your trip to the emergency department that day for unexplained abdominal pain uncovered something far more serious than anyone would have ever imagined. You showed up with abdominal pain and left with a cancer diagnosis. Ovarian cancer specifically, spreading quickly and aggressively despite your young age and previously perfect health. On that particular day in clinic, I remember the enthusiasm as I walked in the room. You wore teal and proudly brandished your phone. I was intrigued as you quickly located a photo you wanted to share. You stood by the ocean, the wind in your hair and the sand between your toes. Your extended family surrounded you on either side like a huge hug, and each of you smiled so hard it radiated through the screen. Your mom, your best friend, stood closest to you. She was the only one whose eyes weren't on the camera. She was too busy looking at you, beaming with pride and with a special understanding of all you had been through in the months that had preceded that moment. Your mom bore witness to a lot during the course of your diagnosis and your treatment, not the least of which was the complex range of emotions around conversations and testing to determine whether this disease would also affect her other children. I marveled at both of your strength and vulnerability through it all. On that particular day in clinic, my eyes stung and I did everything I could to fight back happy tears. I try hard not to make my work as a physician about me, but I care and I always will. After one particularly difficult treatment about halfway through, one that momentarily seemed to puncture your normally ironclad resolve since we both knew that your prognosis had changed, you told me about your plan. A plan that served as our mutual motivation to reframe and widen our definition of treatment success, and one that reminded me that life is as much about the little things as it is about the big ones. All I want to do is stand by the ocean and see forever out in front of me. And stand by the ocean in the purest of joy you did.
Thank you. Thank you so much for your time and for your participation. And sort of in summary, this is how we try to leverage the role of storytelling and cultivating empathy and perspective taking. And again, with that, I will yield the floor. Thank you.
Thank you very much, Anya. And so before we get to a short Q&A here with all y'all, we do have a few more slides that I just want to share, just a few on activities before our next learning session. So a little bit of homework. I'm gonna get here. All right. So in the sort of in this action period, I'm gonna move my video around right in the middle. We essentially have 3 activities for you, 3 things that we want you to do. We want you to first review the Bring Your Brave, talking about your family history of cancer, the overview page, provide your impressions. You're going to get all of this in detail in these slides, but we would like you to review at least 3 videos and consider them from a narrative medicine perspective, right? How do these videos resonate with you personally, with you professionally, with the way you teach, with the patients that you see in clinic? So just sort of give us that feedback about how these stories impact you and resonate with you in your practice. We would also like you in the second activity to go to the Story Center and review, again, at least one story from the workbook in there. Excuse me. Watch the video, and then again, provide us a little bit of feedback in your impressions on those provider videos, and then select at least one provider story, and again, provide us your impressions and your feedback from this narrative for medicine perspective. And then finally, review the Cognito and share your impressions about that tool that you'll have at your disposal. And again, like I said, Rebecca will be sending these out to y'all. So what's next? Expect this email from Rebecca. You'll have this action period tool that will outline all of that stuff and tell you what the expectations are. Google Drive link with all the resources. And as you can see, on March 6th is when we expect the feedback, when we'd like the feedback. So, about a month, a little under a month. And then you can see that we have our further learning sessions already scheduled about once a month until the end of June. And if you have any questions, your first line of contact is Rebecca, though I can guarantee that all of us on the call tonight and on the advisory council will be happy to answer your questions and talk with you if you have anything that you'd like to discuss with us. So with that in mind, I'm going to stop sharing and open it up to any Q&A, any discussions, anything that you folks would like to ask of us or bring up for the evening. We still have a little bit of time.
I just want to say thank you, Philip and Susanna and Anya, for those great talks. And if anyone has questions, comments, feedback, things to share, you feel free to raise your hand or unmute yourself or put it in the chat. Any way is fine.
I have a comment. We've been rolling out hereditary cancer risk assessment in the past couple months, actually. So this was very timely at our community health center in Lawrence, Massachusetts. And providers have been concerned about basically shared decision making with our patients about life insurance. And making sure that our patients are aware of sort of how a positive test might affect them. And I've done a lot of, I also need to be tested for this right now, which is also why I'm involved here. But I think there's reasons that your negative test could really help you with life insurance. Also, your following screening could help you with life insurance. But I just wonder if anyone has any thoughts on that, or if we're going to talk about it in the future.
Fantastic question. And as someone who's given a talk on the ethics of genetic counseling in primary care, it is a very important topic. And I don't know, Suzanne, I would ask Scott or Anya or any of the other folks. I don't personally know if that's going to inform any of the sessions, but it is super important. And if not, then I think we could definitely foreground some of that.
I do think one of the things we're hoping to learn from all of you is what else do you want to know about, right? How can we make this easier for you to implement in your training program, in your clinic? So we will be keeping a list of those things. And I think it's FMEC's duty then to kind of find those resources and maybe do some additional webinars or communications around them.
Yeah, this reminds me of, I teach the informed consent process for genetic counseling at UMass Chan. And this is one thing that we're very clear about discussing with medical students when they're role playing this, is talking about the role of health insurance, life insurance, depending on the results of the test and how to do that and how to navigate it. So thank you very much, Elise. I think that's a very, very important topic and something that we should give back to y'all. Right?
Well, I know some of you have questions. this is, don't be shy. This is a learning collaborative, and as we go along, we're going to, especially in our the next sessions that are coming up, we're going to be asking you guys to really jump in and give us your opinion and give us your feedback. So, is there anybody else who has anything?
I'll just mention while we're waiting, we really appreciate all of you who completed the pre-survey that we asked you to complete so far. I think we'll still get a few more coming in, but it was eye-opening for us to hear kind of your thoughts and about how prepared you feel and where you are with narrative medicine and cancer screenings and referral. And we'll be sharing those back to you all in the next week or so. And then hopefully discussing a little bit of them next session. And next session, as we kind of already alluded to, it's going to be a lot of your kind of impressions, feedback, thoughts about the materials, what you want to do next. So this was the one where we kind of put it all in front of you. And so you didn't have to talk, but you will next time.
All right. Well, I think that Scott, I think so. We'll stay on for a while if anyone does have anything that comes up, but we will. I think it's okay, Scott. If you're fine with it, we can release everyone for the evening. Thank you again very much for your attendance tonight. Please be on the lookout for that email from Rebecca, and we really look forward to your feedback and your impressions and your experiences with this campaign. And we're really excited to deliver this content and collaborate with y'all for the next few months.